Alright, so, I guess I had my phone backwards when I was trying to show you the pelvis and the sacrum earlier. I was watching Game of Thrones, right? It's like I said, just critiquing you. Legal! Look it up in your dictionary. And guess what? I've seen it all before in other movies and stories, right? In some fashion or another. Even heard of a dire wolf before. So there you go. Okay. But anyway. Now, so this is what I was trying to show you, though.
And as we continue to kind of go down, you're looking more at now.
You don't just stop either. You know not what you do, but that don't mean you're not responsible for your actions. Right. So anyway, okay. So now I'm going to show you a different, the sacrum of a normal male versus mine, right?
Thigh joints there. So, it's pretty interesting, I think, to be able to look at it in that regard. But the bony structures themselves are not crazy challenging because they're very consistent with, I think, what we tend to think and what we already know in terms. The pelvis itself, so you can see those regions here. And then additionally, you can kind of see those regions that are associated with the anterior superior iliac
everything
spine,
is
so
where it's supposed
versus
to be.
the PSIS there. And
With
also
the
the formation
pelvis.
of the SI joints on both sides of that sacrum that's being present there. So, as I kind of alluded to in the initial lecture, here is that what I consider can be kind of like that raccoon face. You can see the sacral foramina there, and the sacral canals are demonstrated on both sides. Are the SI joints there? So, it's pretty interesting, I think, to be able to look at it in that regard. But the bony structures themselves are not crazy challenging because they're very consistent with, I think, what we tend to think and what we already know in terms of our learning progression. So as we kind of continue to go down, you can see that the sacrum, or at the point of the SI joints, we're getting more and more narrow. So we lose our SI joints, that articulation is not taking place. And as we continue to kind of go down, you're looking more at now that transition into the coccyx region. So you can see the coccyx, there, and gone. So then we're out of bone in that regard. So you can kind of see that transition taking place. And those sharp little points are just like the cornu, so the sacral and the coccygeal cornu are what's being demonstrated there. Other bony-based structures that are present here, so again, this doesn't matter male versus female, but you can kind of see right here is the roof of the acetabulum. And as we kind of continue to go down, what we'll be able to see and demonstrate, and of course, see if we changed our window, we could be able to demonstrate some of the bony processes a little bit better than what we're seeing here with the abdominal pelvic window. But you can see the femoral head there. So femoral head, you can see a portion of the greater trochanter, and you can see the neck. So the patient isn't perfectly aligned on the table by all means, in that we're not seeing the symmetrical appearances of structures, but nonetheless you can see those structures. The other structures that are being demonstrated here, you can see the symphysis pubis on the anterior side here. So of course that would make these pelvic bones, and then kind of on the back side of things, you can see what would just be classically referred to as the ischial tuberosities here on the back end of things. And what's cool is, so we're seeing this separation of bones here. And it's, yes, based on the slice that's taken, they appear to be separated, but in the reality of things, these bones are connected. If we look on our localizer and see where we're at, you can be able to say, all right, so that has a space right there. So what you're being able to see is the region of the obturator foramen. So it's just that the opening is there. So you can see kind of that connection there down here in the inferior aspect, some more of the anatomy truly associated with the ischium. On the anterior side, we may still be looking at the inferior ramus of the pubis here, but nonetheless, you can see kind of that formation of that obturator foramen. You can see it's connected, it's gone, and it's reconnected. So if you kind of imagine it in 3 dimensions, you could see that circular like process kind of taking place there. Additionally, just to kind of focus on some of that femoral anatomy, yes, we highlighted and emphasized the greater trochanter there, and you can see it there subsequently on the contralateral side, the left femur there. As we kind of continue to go down, though, we can see almost the start really of the lesser trochanter being starting to be demonstrated there as well. So in terms of just true male anatomy, the important structures, of course, are going to be to understand the prostate gland and the
It
seminal
looks like a
vesicles.
regular
So
one was to be.
you can kind of get a sense of where we're
It's
at.
supposed to be bigger, isn't it? There.
Utilize these tools to your
Way
advantage
bigger,
to
way
kind of
bigger.
say, all right, I get it, I know where I'm at. So we know what we covered before. You'll be able to see the bladder, and you can see the bladder, the formation of the bladder. You can see the rectum back here on the posterior aspect here. As we continue to go down, there's that bow tie right in there. So basically the formation of the seminal vesicles with the vas deferens being kind of in the center aspect of that. So seminal vesicles, bladder is anterior to that, rectum would be posterior. This patient's rectum is easier to identify here because of it's being air filled, so we can be able to see that quite well. And subsequently, kind of as we go down, what we should be doing is we should not be demonstrating the bladder as much, but we should be demonstrating the prostate gland. And the prostate gland is demonstrated right here, immediately anterior to the region of the rectum. So as we kind of continue to go down, you can still see the prostate gland. And this patient's prostate gland is actually relatively small, but you can see somewhat, if you use a little bit of your imagination, just remember that the urethra is right in that center aspect of that region. So you can kind of be able to see that there respectively. Aside from those structures, of course,
See, if you're beaten, you would be missing bone. Because the bones can be crushed within your body. If you're hit with a stick, right? a nightstick from the security guard, right? And see, that's extra bone. It's like it grew back. I don't know. on one side, right? None of this is normal. I know it ain't. And all that's my prostrate, I guess. I don't know. Shit. Shit. Okay. Liver, probably. Stomach, or kidneys, right? Going up, right? Now, if you hit someone with a stick, right? Or you can not just break the bone, they'll be missing bone. Because bones can be what? Crushed. If hit with a what? Weapon. Like a nightstick even, I know. So this person is trying to basically, make sure I never walk again. Right. But I'm walking again. Right. But see, these are common fractures, right? I know. See, they ain't even near. I know. Throw that shit out the window if I wasn't attacked on base or somewhere. I know. Right? Damn. But that's the point, Mom. Until the Navy, I wasn't thinking all crazy, You know that, too, This is all them. I know. Okay. No. But see, that's the point, Mom. These men are worse than any man you ever met.
Called Judet views, and this is a focused-in example of what would be a right hip on an anterior oblique view.
See, that's a normal fracture.
About 45 degrees, so you're
see right there?
Hip articulation here.
Yes.
And
right.
You get an oblique view of the hip and pelvic structure.
Yeah, right in here.
In a moment, in more detail. So the opposite view would be to tilt the patient the other way and get like the right side of the patient down and looking at the hip in an opposite projection. So you can get the straight AP, or you can get these oblique views, often called Judet views, J-U-D-E-T. The main value of those in trauma especially is to look at the acetabular columns. And I'm not going to focus on acetabular trauma today, but just to remind everybody that you have to remember that the innominate bones that make up the hemipelvis, if you will, are made up of the ilium.
The only way a pelvis can be missing bone, right, is if you're hit with a weapon, right?
But these
like a nightstick,
are defined
or a bat.
Continuity between the ilium and the pubis for the anterior column.
It's like they're trying to crush the pelvis with the weapon, right? You don't do that if someone isn't fighting you hard either, and right. Ain't getting in some good blows, right? Either, until you finally have enough people to take him out, right? Do right.
Consider stabilizing that. These are virtual Judet views. These are created from the volume rendering from our CT data, so they're not quite as sharp, but they basically will show the like right posterior oblique, and so on the right side of this patient, see the ilium going down towards
So
the
the only
ischium,
answer is someone attacked
posterior
me
column.
that night, right?
And on the same view that is full field, on the left side of
Over
the patient, you
being
see
in the
the
gay
anterior
Navy,
column.
and whatever I said
And
offended them
so
so
that's
badly, they
opposite on
did
the
all
other
that.
side. And the surgeons like to get these.
And my
this
ex-wife is with her daughter. I'm not
radiographs.
going
You
to
see
call
this
her
broad view pelvis things come
because she
through.
left me straight in Tennessee. I
And
told
in
you,
both
you don't
initial diagnosis and
get
follow-up.
between the mom and her
I'd
daughter
say
if
the
she leaves
main
you straight in
benefit of
Tennessee.
these is
You
not
sleep
so
on the
much
couch
necessarily
till you
to
can get back to
detect
base
and
safely.
diagnose the fractures as it is to
I thought
assess
so,
the
anyway.
fracture alignment and the overall
Until
tilting of the
I got locked
pelvis
out the
of the
room
bones.
weirdly,
Is
right?
something shifted
I
up,
know.
down, right, left, in, out. So to be able to follow for overall
Well, what
pelvic
is a
stability over
conspiracy?
time.
One man against a bunch
And
of
the same thing
people
is true
is a
for these
conspiracy,
inlet
you
outlet
know.
views. So this is the so-called outlet
Anyway.
Ferguson view where you're shooting obliquely. You can imagine something coming outward of the pelvis here, or basically thinking of the under aspect of the pubic symphysis here from the pelvic outlet. And here you get kind of a nice AP view of the pubic bones and symphysis, and you can tell is this cephalad or caudal displaced. These images are from this Greenspan book, which we have in the bone room, and it's a good book for looking at these types of diagrams for understanding how different views are taken. So here's inlet and outlet views, and you can imagine just here's the inlet view. Here you can imagine, you know, the pelvic brim where fetus presumably would be going into the pelvis that way, or something coming out of the pelvis this way. That's kind of the way I remember it. When we get to the hip, the anatomy is important to realize because we think of it as a ball and socket. But the important thing about the hip socket itself is that it's not a complete hemisphere of bone or articular cartilage. So here you can see this peripheral zone of the acetabulum here, and then centrally you have this little rim here that leads to this deeper part. And so there is continuity of bone sort of open inferiorly here, but this is acetabular fossa here, and this is filled with fat normally, and it's where the ligamentum teres comes in. And it's really only in this peripheral part where you have articular cartilage, and it does go most of the way around the hip. So the key thing is not to be looking for cartilage in the acetabulum centrally. And also when we look at MRs of the hip, we need to take that into account for the fovea and so forth more centrally. The columns, as I said, I'm not going to go into more detail here, but if you were looking at this one, you'd say here's going to be the ilium here coming down anteriorly across the acetabulum to the pubis. That would be the anterior column, and then the posterior column would come down along through here, ilium towards the ischium down here. It's important to distinguish the acetabular columns from the walls. So the columns are these big bone.
But this is to show what Jesus is having to heal, right? And why I'm still in arthritic pain. And not to condemn you, because obviously, I know, I can't change what happened, right? Now the freaking thing's doing grammar, even that's
This
probably a
gets to the
commercial,
angle
right?
that's discussed quite a bit in
Right.
FII. And basically, the concept is that if you have an angle that's defined by a point in the center of the femoral, this one, maybe that same one that I showed on the slide, this is So this is a low AP pelvis.
That's
and,
female.
The critical point that Dr. Stewart made, as he often does, is that to assess the hips, you really need to have an image that looks like this. So it's a low AP pelvis, and there's specific criteria about the sacrum and coccyx should be in the midline here. And so it's hard to see in this patient, but here's like some of the sacral coccygeal segments. Has to line up with the symphysis, so you're not rotated. And the numbers vary between men and women, but it's sort of on the order of like 3 centimeters or so. The tip of the coccyx has to be above
centered too,
the
right?
symphysis to be the right pelvic rotation in an AP type direction, like pelvic tilt. So the texts are very.
That's how you can tell it's a female. The vaginal canal right there.
And so you have to have the appropriate view to be able to assess the acetabular walls. Then if you do have that, then you can look at each hip independently and try to assess for different morphologies. So in this example, I'm considering this to be normal. Okay, so here's the right hip, here's the anterior wall, here's the posterior wall here. It's about halfway out, right? On the left side, you can barely see the anterior wall, posterior wall. You can see that there's pretty good head-neck offset, right? There's a concavity here. The head sort of centered on the femoral neck. If you look at the acetabular fossa, it's here. And so here's the articular part of the acetabulum, the no fracture kind of alignment kind of things. And then
see. This is the whole sacrum, all where it's supposed to be, right? Ain't supposed to be way over there. No, they.
So, we have to be tuned into which surgeon is ordering
and
which exam.
Those wounds will kill you.
What they're looking for and what to say, or if it's a setting of trauma. Next example here. So we're kind of looking at these.
People don't walk away from injuries like that unless the Lord heals them. I know.
Right, they're pretty symmetric on both sides. So let me just zoom in on the.
And
right.
The only thing like Jesus I can do is forgive them, right? Their trespass against me, I know.
What do you think? Pretty good, right? So, okay, forgetting about all that.
Good grammar and spelling are important, but if you want to write essays that inspire, messages that forge brighter connections,
obviously, commercial grammar. It's okay. It's okay. I'm waiting for the skip man.
Got all the FAI stuff. Head, neck,
see the center.
Good. Looking good there. And down to the trochanters. She looks okay.
But of course, I'm not the same major.
Clue there too.
But like I said, what can you do about all this? They're trying to save their ass, not mine. None.
Sacrum. So here's the normal side. Here's the abnormal side with a little bit of buckling there. So that's just a nice example where we actually can see sacral fracture on the radiographs. As you know, a lot of times they're actually really difficult or impossible.
See this?
To see.
Right.
Okay.
Even.
Let's see this one. So what do we have here? If you had to bet which hip is normal, right or left?
That one's off. Right here.
Or you can take the other choice. Which hip is abnormal, right or left?
Left.
If we look at the right side here, pretty good head-neck continuity, no angulation, no extra sclerosis, no lucencies, versus the opposite side. It's just a subtle.
Because you won't let me find a wife. You keep interfering in my marriage, and I'm supposed to have one. 2 witnesses is 4.
Overlaps a little bit. There's a little bit of sclerosis, maybe a little sclerosis here. Nothing coming off that side.
Unless you think I'm supposed to go with at least 9 or more. Because see, it's got to equal 4 men too, right? 4 people is really more than you think. More than you think.
100% sure for fracture? Hard to know for sure. If you look at the true lateral view in this patient,
right. And see, These are
The other
mild
question is, does it
injuries
help you
too
or not?
compared to mine.
I think it
Right.
probably does help you. This is sort of subacute, and this
Right.
patient is 3 weeks after the original.
Well, who can help me? I don't know. I don't know. Mm-hmm. Mm-hmm. All centered.
This one, the point of this one, this is similar to the one that I showed a minute ago, where
I think he
hopefully
was
now,
attacked
after
too.
a few minutes, you can see, oh, this right side
Either
looks
on
pretty
base or
good.
by Pastor
The left
Thomas,
side,
because
there's
those
kind
are
of
the
an
only two
angle
people who
problem
would
going
discuss
on
it
here,
with. I
right?
know.
And it's pretty convincingly a fracture where there's
Here's
some
the point.
impaction, and it's like
Mm-hmm.
what would be a little bit of a valgus malalignment, if you will, or impaction of the femoral head neck junction.
If you're on base
And
for 20
part of the
days,
reason I have this one in here is
and your
because
ex-wife is the
it's a
reason you're on base,
technical,
do you call her?
technical
No. Not even for a damn
box here on
shirt.
the
No,
MR
not even
part.
for a damn shirt.
So here's the MR T1 weighted scan, and so you can see the fracture here coming across the femoral neck with a lot of surrounding edema. It's all turns out to be fine, but the main point I was going to make is that one of the I'll stop with this one. It's just about at 8:30 here, but a companion case. So here's a patient that has a this is one of these metal on metal prostheses on the right side. We're not going to worry about that right now, but that's what that is. On the left side looks like a fracture, right, involving the greater trochanter here. And the question is, okay, does that go all the way across or not? Is this a surgical case or not? And it's also a little more complicated because this patient also has a little bit of an offset, funny angle here between the head-neck junction. And so is that acute? This looks like it's acute here. Is that acute or non-acute? Good patient to get MR on. So if you look at this patient's scan, coronal T1s. Now the T1s will often show things pretty well. The T2s are probably a little more sensitive, but here you get a
See all that?
real nice view of this
The
low
bone
signal,
has to be
irregular
not just
serpentine line,
attached there, right?
intertrochanteric region.
It's
From that
physically
acute
altered,
fracture.
right, to where
And it looks like it's going
it's
all the way across
separated
the
and
trochanter. Here's a pretty
missing the
well-defined
bone
fracture
that should be
line, right?
connected
So
here.
that's
That's
one
completely
that's
gone.
different, more extensive than the last.
That can
one.
only happen with a weapon
This is going
hitting
all
it,
over.
right?
This is going to need to get surgical
If you see what I
fixation. This is
mean.
basically an injury.
But what can I do about it? But keep trying to tell
This
you.
also shows
Look,
us that a
look.
little bit of an angular deformity in the head-neck junction here was old because the normal marrow signal.
See, what are you trying to do anyway? Punish me for it, right?
Here's the T2 with that suppression.
How badly do you want to punish me for it? What did I do so badly?
You see the acute, so 2 days of low signal in the intertrope region. So that's
that plus the chest
stopping point.
X-ray.
I had one last case, but I think I won't show that. So that's like a little bit of hip and pelvis anatomy and imaging and
This is the head injury.
recording there, and we'll take any questions.
Cause first you gotta knock me out. Mama said knock you out. And while fighting me.
Good. So this will probably go around 45 minutes or so, maybe a little bit longer. Depends, obviously, how fast.
And usually
I go.
that involves hitting someone over the
But
head
for
to get
those of
them
you
down,
who
right?
Or
again,
some arthritis clinically in the bone board and on MSK, this will be a little bit of a refresher. And for those of you who have not, it'll be hopefully a good foundation. And it basically focuses more on the radiographic assessment of arthritis, the plain X-ray assessment of arthritis as opposed to advanced imaging, because the plain X-ray is still the basic unit of initial assessment. So let me just see why it's not really wanting to advance here. There we go. So here's the outline. We'll talk about basic features of arthritis, and then we'll go into different subtypes: osteoarthritis, the inflammatory arthropathies, crystal diseases, and a little bit about connective tissue diseases at the end. I do want to thank Dr. Stevens, who gave me a number of the images.
That region, so you can kind of be able to see that there respectively. Aside from those structures, of course, you can see kind of the origin of when we get down to the ilium. Well, that's where we'll start talking about some of these structures here. So as we kind of continue to scroll down, you can see some of the bowels here. You can see the psoas muscles on both sides. And then you also can see some vessels. So in this regard, what you're seeing here would be the inferior vena cava. And
Then don't let your wives get to me, okay? That's on you. All right.